All right, I'm Dr. Ebonie, again here at the Indigo Hotel in Los Angeles, California, and I am with Mr. Mike Griffiths. He's with Advanced Oxygen Therapy Incorporated, and we are going to talk about how to heal a diabetic foot wound. This is what we see a lot of in podiatry, and this is a great way for in-home therapy. So without further ado, I'm going to let you describe your company and describe what your therapy provides.
Absolutely. So we're Advanced Oxygen Therapy, and we provide an adjunctive modality, which is a multimodality, using cyclical pressure topical oxygen. So here is when podiatrists or physicians treating the patient with a non-healing diabetic foot ulcer, they can order this in addition. We set the patients up at home, they do the therapy at home, and it allows us to deliver oxygen under cyclical pressure, which combines non-contact compression to reduce any edema that might be present, and it's needed humidity, and all of this helps the wounds heal.
Wonderful.
Yeah.
And just for clarification, sometimes the diabetic wounds, they go to wound care.
Yes.
And in wound care, they are provided with hyperbaric oxygen chambers.
Yes.
Is this product in addition to or in lieu of?
In lieu of.
Okay.
I mean, full body hyperbaric changes where the patient's whole body goes in the chamber.
Right.
Obviously, have proven to be effective, certainly on diabetic foot ulcers, but there are many contraindications and risks,
Right.
and many patients just don't qualify for various reasons.
Right.
So they're generally, because of that, used as a sort of end stage when they've tried everything else. Ours is something where you can use a lot earlier. So if you have an ulcer that's just not healing with all the care that you're doing and stalled and just not progressing and maybe going in the wrong direction,
Right.
then ours is an option that you can use at that stage. You order it, you continue to do good standard wound care, good debridement, appropriate offloading if it's a diabetic foot ulcer or compression, and you order this in addition. And we set up the patients, they do the therapy at home, they come back in for their regular wound clinic visits, and hopefully the wound's progressing and you continue until healing.
And you do this every day, 5 times a day?
Our recommendation protocol is 5 times a week, 90 minutes per session, and that's what our studies have shown is effective. But there's really no contraindication to do it more often, but that's sort of the minimum protocol.
Right.
Yeah.
And a lot of times with diabetic foot ulcers, people apply wound vacs.
Yes.
Can this be in addition with the wound vac intact?
The only thing that you can't do is you can't have dressings or things like wound vac that create a barrier for the oxygen to get to the actual wound tissue, because it has to diffuse in. So negative pressure or wound vacs really can't be done at the same time. It could be done serially. But what we found is, if we look at the evidence for our studies, is we are particularly effective in chronic wounds, diabetic and venous ulcers that are stalled, whereas negative pressure, although it's used in diabetic ulcers, is usually more exudative infected wounds.
Right.
So it's sort of horses for courses and picking the right tool at the right time. So what we find is, if you have a wound that's stalled, we believe we should probably be a frontline therapy. And in many cases, if you have patients with gas permeable dressings, which most dressings are, they leave the dressings in place and they do the therapy at home just over those dressings.
Right. So just as a timeline, if someone has an infected wound, you can take them to surgery, debride the wound, apply a wound vac, and maybe a month later start this, or maybe even right away, don't even apply the wound vac.
I think you have both options. I think the reality is as a clinician, it's another tool in your tool belt to decide when to use.
Right.
We would because the benefit of oxygen in wound healing, the first thing it does is help kill directly anaerobic bacteria, but it also provides fuel for the neutrophils to take on other bacterial burden. So we see a significant upregulation in leukocyte function and the body's immune system, and because of that, then obviously it's very effective on infected wounds. So clearly using it earlier is probably better. But if you have a lot of bioburden and you want to use the vac to remove that for a while, there's nothing wrong with that either.
I completely agree with you. Like, not everybody is a great candidate for the hyperbaric oxygen chamber. And so this is like a really amazing tool that you have, especially because it can be done in the comfort of your own home, right?
And that's the real benefit. I think one of the biggest issues with full body hyperbaric are the risks and contraindications, but also patients have to go 4 or 5 times to a full body chamber center, for 2-3 hours. It's very difficult for many. And many of these patients are comorbid with lots of other diseases.
Right.
It's not easy for them to deal with that. So what we see is, certainly if a patient doesn't qualify or this isn't a candidate for full body hyperbaric, this is a good alternative. But unlike full body hyperbaric, where it's used later in the phase when nothing else has worked, because it's really only covered at those end stage wounds, our therapy can be used much earlier in the process. And the sooner you use it, if you take it on the wound that's stage 1, stage 2, University of Texas ulcer, the sooner you use it, we find the sooner the wounds heal. And what's very exciting is we've not only seen from real world experience, but from our latest multi-center, double-blinded, placebo-controlled study that's published in Diabetes Care, we showed that we were not only 6 times more effective at healing at 12 weeks, which is the normal measure, but because the way we heal with oxygen, we lay down better quality collagen and we have better vasculature, angiogenesis feeding it, that we followed these patients over 12 months and had a 6-fold reduction in reoccurrence.
Wow.
Which to me is because clearly with oxygen you can heal the tissue with better quality collagen and it's better perfused. And these to me are the exciting benefits, not just the short-term but the long-term benefits, which ultimately both to the patient's quality of life but also to the payers, to the cost of care, is beneficial all around.
That is beneficial for the doctor, for the patient, for everyone involved.
Exactly.
It just
and what I like about it, as a physician, you come to your practice, you have tools that you use that work. We're not asking you to change something that you use. This is adjunctive at home. So what we ask is order this additionally, and our job is to make sure the patients are compliant. Because if they don't use the therapy, it doesn't work. But we find we get very good compliance because it's very easy for them to use. They're doing it whilst they're sitting there watching TV like they would be probably doing anyhow. And what we find is that the patients take more ownership in their wound care because they see progress quite quickly. And that's the worst thing, as I'm sure you see with patients diabetic foot ulcers or venous ulcers, they lose hope and they get depressed. And if they finally start seeing progress on something where they've been told maybe it's not going to heal, maybe they're going to have an amputation, and suddenly they see it improving, they get very motivated. And we find if they're able to, they use it, and if they use it, they get outcomes.
Absolutely. So how does a physician go about getting this covered for their patients, or what's the process of that?
That's a very good question because everything is coverage, as you know, particularly in home care. And so at the moment we have coverage in the Veterans Administration and the federal government through our federal supply schedule contract. So any veterans facility or VA choice patient or patient on home, being seen outside of the VA in the community care programs is covered there. So the physician could order it and it will be paid for and provided by us on contract. Indian Health Services, federal government facilities are covered as well. We also have coverage in New York State Medicaid, so that sector covers it. So people don't realise, I don't think that Medicaid has expanded enormously as part of the Affordable Care Act, and in New York alone there's over 7 million people on Medicaid. So we're covered there at the moment. Now with our latest state-of-the-art study being published, we're now in the process of soliciting broader coverage through Medicare and the private insurers and everything else. So we expect over the coming year and 2 years, we will sequentially hopefully get more and more coverage so it will be available for everyone.
I hope so, because I think everyone needs that, especially diabetic foot wounds are difficult. So having this product available would be just really beneficial to everyone.
And what's nice about it, we're not asking you to change your practice. Do the good things that you should be doing, good debridement, good offloading, appropriate treatments in the clinic, and you can add this on top on wounds that aren't responding appropriately, which there are many of, and we get them to healing, and they seem, because of the way they heal with oxygen, to stay healed longer, and the science proves that now. We have the same evidence also in venous ulcers. So another area, because of our therapy delivers non-contact compression, it helps reduce that edema that's present, which is a major reason venous ulcers don't heal. So we see the same sort of outcomes there as well.
That's amazing. So with the venous ulcers, there's a level of compression that definitely needs to happen. With you saying that the dressings can be intact with that, like you're saying a Pro 4 wrap or an Una boot could be intact and you can still...
And we do the therapy over, and that's key, because unlike diabetic ulcer patients where quite commonly they change their dressings at home and they tend to be simple, most venous ulcer patients with compression dressings don't, because there's a risk of dangerously applying it, inappropriately. So if you had a therapy where they had to replace those dressings, it would probably be difficult. You'd have to send the nurse out, wouldn't it? In our case, whether it's a Pro 4 or a Coban or any compression dressing or an Una boot even, those dressings are not gas permeable. They're not designed to block gas, so they're completely gas permeable. So we do the therapy over those dressings. So easy for the patients.
That is so perfect.
And even the diabetic foot patients, if they have simple dressings, they leave them in place. They don't have to remove them.
Well, I'm a fan of your product.
Thank you.
I think I will try to use it if I can. I hope the insurances kind of get on board with it.
And I think they will. I think from our perspective is the evidence bar for coverage has been pushed higher and higher over the years. And in wound care, evidence hasn't always been the strongest. So we just completed a multi-center, multinational, double-blinded, placebo-controlled study, the highest level evidence you can do, with incredible outcomes, with top people around the world, published in the top peer-reviewed journal in the space, Diabetes Care, the highest impact factor in the diabetes space. So we've done the highest level evidence. But what I think is also exciting is we have lots and lots of health economic data. We've treated over 20,000 patients in the US already, and we have a lot of data on that. So we're working now to publish a big health economic study that takes that prospective data, articulates those outcomes with the registry data to project what the potential benefits are, then reduction of amputations, hospitalizations. Because really from a payer point of view, if we can demonstrate not only do we have strong efficacy that you should want to use it for the ethical reasons, but the impact of that is also a quality of life and a cost-saving benefit. I mean, the reality is we have to address both.
Absolutely.
And I think this therapy has that benefit, and it's a therapy the patients do at home, which is the lowest cost, the best compliance.
And I think the access is one of the main reasons why people are not healing their wounds.
No, absolutely.
Missed appointments for wound care happen all the time. Missed appointments for podiatry, can't get a ride, can't move around. Like, if you just stay at home and heal it, you're good.
Yeah, and that, I mean, when we go into patients' homes, when we came up with this therapy, they said 5 days a week, 90 minutes, no one will ever use it. We said, well, hold on, because my background before wound care was in respiratory care, and there's a lot of issue with patients using respiratory products for sleep apnea. Compliance is a big issue. So what we found, though, is we find not just in our studies where we had, we mandated and we had wonderful compliance, but in the real world, in the 20,000 patients we treated, our compliance is really high. Because when you go and train them, you go into homes, and we as a accredited DME, we do that. We go and train the patients how to use the therapy, and it's important that they use it, otherwise nothing works if you don't use it, and you shouldn't be paying for it if it's not being used either. Or should the insurer. So we believe on both sides. So we make sure that they're compliant. It's easy to use, and as we say, we set it up in the way that where do they spend most of the time? Where's their comfy chair? Where they're sitting, or if they're bedridden, where they are. And we make it as easy as possible. And the approach of the delivery is so easy that they, what we find is they take some ownership of their condition.
Yes.
If they start seeing progress, they get motivated to want to use it.
Right. Well, it's definitely a team effort.
Yes.
The doctor and the patient have to be working together.
And we're in the patient's home. So one thing we always do is we believe that if someone orders our therapy and we set them up, and that patient comes to clinic for their wound visits, either weekly or bi-weekly, depending on their schedule, and you're not seeing as a clinician some improvement in the wound, whether it's reduction in size, volume, more granulation, less exudate, something that shows it's getting somewhat better, and they're using our therapy, we generally find it's due to one of the two reasons. One is maybe there's not adequate debridement being done, which in the US with pediatric surgeons isn't so bad because you're surgeons. Outside the US, it's not always surgeons doing wound care, and their scope of practice doesn't always allow them, or they just don't understand the importance of good debridement. So assuming it's not that, the other reason is they're not using it. It's compliance. It's as simple as that. And that's our job, to make sure they do what we can to make sure they're compliant. And if we go to a patient's home and for some reason we believe they won't be compliant, you go to a home, maybe they're a hoarder and you can't even get in the door. We're going to come back and we're going to tell you that, hey, we'd love this to be, but maybe that's not a good choice for them, for you, and for the payer. And I think if you're ethical about the way you approach that all around, then we do find that the vast majority of patients, even if you wouldn't imagine would use it, do use it. I mean, we treat patients, 20,000 patients, veterans, and New York Medicaid patients. I mean, these are areas of the population where the quality, they have a lot of issues that they're dealing with. And if we're able to get the compliance we get there, we believe there's no reason we shouldn't get it anyway. And they're so grateful, these patients. And you see it. You see it in the patients you treat. When you can make a difference and save a limb, save a life.
Heal the wound. They're so grateful.
They are, and they take that. And I mean, to me, it amazes me when you look at diabetic foot ulcers. The studies are out there that the one thing that is you can correlate with mortality in diabetic foot ulcers is a degree of clinical depression.
This is true,
And I mean, and it's the one thing we don't do much about.
6 months, 8 months of a wound, and they just enough to depress anybody.
They do, and then if they start losing, limbs, and they know that's their, they lose their mobility, then their physical health goes down, and it really is. It's horrible for them. So if you can do something to heal a wound, save a limb, and the saying, save a limb, save a life. It's true,
absolutely,
because they're less depressed, they mobilize more, and all of those things add to their quality of life and life expectancy. So.
Well, thank you so much for speaking with me. Again, this is Mike Griffith. Excellent product. I think that all podiatrists should definitely consider this product for their diabetic foot wounds. So again, thank you for speaking with me.